Hello, this is Mrs. Donna Sattler, and this is the lecture for Chapter 22, Med Surg II, Care of Patients with Head and Spinal Cord Injuries. So let's discuss classifications of head injuries. First of all, closed head injuries. Closed head injuries is just that. It's some type of injury to the head where the skull and the scalp remain intact. There's no breakage or opening to any of the areas, versus an open head injury is there's some type of laceration to the scalp and possibly and a fracture to the skull, which could lead to some type of brain damage. A coup injury is when you hit your head in one direction. So say for instance you hit your head on the frontal and have just injury to that front area of the brain, versus a contra coup, you have you hit your head at 2 points. So you hit your head towards the front and then you hit your head again in the back. So kind of like shaken baby syndrome, when your head is going back and forth. So you hit it at 2 points. You hit it once going forward and then you hit it again going backwards. Is contra coup, versus coup is just when you hit your head once, one time, going forward and possibly causing brain damage. A missile injury is just an injury like a war type injury of some sort. We have different types of just injuries to the scalp. So you have an abrasion, which would just be some sort of scrape or something to the scalp. A contusion, which is actually a bruise to the brain. A laceration, there's some type of actual tear or wound to the scalp. And a concussion is just it's a closed head injury. And so with a concussion also, you're likely to lose or have some type of disruption in your level of consciousness. With a concussion, it could be brief loss of consciousness or extended period of time, depending on the extent of the concussion. So like a lot of sports injuries, you see sports is like football or something like that. Those individuals tend to have lots of concussions. So it's a minor closed head injury. And remember, we said a closed head injury, there's no penetration to the scalp or the skull or anything with that closed head injury. Okay, so with our skull fractures, we have, different types of skull fractures as well. So there's a linear skull fracture, which is just a single simple line or crack in the skull. A comminuted skull fracture would be one that's fragmented. So it's not that nice single line with a comminuted. Depressed skull fracture, the skull fracture, the skull actually goes inward. So maybe say if you got hit or something and the skull actually was pressed inward, that would be a depressed skull fracture. And then a basal skull fracture is one that happens at the base of the skull. So let's talk about our older adults. Something that tends to happen with our older adults when we're talking about the neurologic system is their brain tends to atrophy, which simply means the brain gets smaller. So when the brain gets smaller, that leaves more room in that cranial vault. So if that individual falls, then there's more room for that brain to move around in that cranial vault. So if there's more room for that brain to move around, then there's more risk for injury. So small vessels can get injured, and so that puts them more at risk for subdural hematomas, which we'll talk about here shortly. And so one thing you need to remember with our older adults, that's why you'll notice when they have a fall in the nursing facility, especially if they hit their head, they're on neural checks. So you gotta really watch them, for those issues. If they fall, because they are more at risk for those type issues. Okay, let's talk about subdural hematomas. What is a subdural hematoma? Let's think about our anatomy and physiology, right? So we have the scalp, then the skull, then we have our meninges. You have 3 meninges, right? Your dura mater, your arachnoid, and your pia mater. And then, the brain. So you have these areas here that are there to protect the brain. When we have a subdural hematoma, there's a small leak or bleed in the subdural space, which is the space under the dura mater. So you have some type of leakage to that particular area. So remember, we said with our older adults, they're more at risk for these type injuries because they have more room for their brain to move around in that cranial vault because the brain atrophies. Another group of patients that's really at risk for these subdural hematomas are patients that are receiving anticoagulant therapy. Anticoagulant therapy is used to help thin the blood, so then they're at more increased risk for bleeding. So if they have this injury, they're more likely to have some type of bleed when they have some type of head injury. Signs and symptoms usually appear within 48 hours of the trauma. There's a decreased level of consciousness. You got to think with any type head injuries, you always want to monitor, level of consciousness. That level of consciousness is going to tell you so much. If a person's level of consciousness is decreasing, then their conditioning could be worsening, from that point. Okay, an epidural hematoma. So how's an epidural hematoma different from a subdural hematoma? Well, first of all, an epidural hematoma is a medical emergency. A person can die actually within minutes to hours of a trauma if an epidural hematoma is not controlled. So the bleed with the epidural hematoma, remember going back to our anatomy and physiology, how we talked about the scalp, then the skull, then you start with the meninges. So that bleed with the epidural hematoma is in this space that's between the dura mater, which is the first meninge, and the skull. So it's a rapid bleed, so it's going in pretty quick. These are, a lot more rare than a subdural hematoma, but if they do occur, it is a medical emergency because this person could die, within minutes. So we gotta, because their intracranial pressure is going to start to increase, which we'll talk about that as well here shortly. But with the epidural hematoma, there's going to be a brief period of unconsciousness. They might have in between consciousness, have some periods of lucidity and going back to unconscious, back to an unconscious state. Remember, I said with all these head injuries, level of consciousness, you got to monitor that patient's level of consciousness, because if that starts to decrease, then that tells you that that person is getting worse. So you want to monitor their mental status as well. This person might have a severe localized headache. They might have some behavior changes. They might have irritability. There might be some ipsilateral paralysis or hemiplegia. Ipsilateral just means one-sided. Same thing with that subdural hematoma as well. They could have, some ipsilateral paralysis or hemiparesis or hemiplegia, as well with that subdural hematoma, but as well with the epidural hematoma. So depending on the type of head injury you have, you might have different signs and symptoms. You might have some bruising, you might have some swelling, you might have some lacerations, there might even be some bleeding, depending on the type of head injury you have and how severe that injury you have will be. Okay, so let's talk about some other signs of head injury. It's based on, the type of injury, as we stated, where it is. So if we have bleeding in the subarachnoid space, the subarachnoid space is the space in the meninges, the area between the arachnoid and the pia mater, would be the subarachnoid space. So if we had some bleeding there, you might notice some nuchal rigidity, which is basically just the neck pain with flexion when you flex the neck. Also remember, with any type head injury, whether it be moderate or severe head injury, we will always want to assume there's some type of cervical spine injury until it's proven otherwise. So you want to, protect the neck, protect the spine as well with these head injuries. Concussion. So remember, we said a concussion was a minor closed head injury. With your concussion, you might have a brief disruption in level of consciousness, amnesia, or a headache. But also keep in mind there's, mild concussions or more severe concussions. If you have a mild concussion, you might notice a headache, dizziness. There might be some memory loss. You might have some confusion. You might not have any loss of consciousness with a mild concussion. Some residual impairment or memory impairment, I'm sorry. Now, if it's a more severe concussion, there should probably be some loss of consciousness there that can last, anywhere less than 24 hours or so with that type of injury. A contusion, remember, we said the contusion was a bruise to the brain. So if we had a contusion, there might you have some alteration in your level of consciousness, and you might also have some seizures. You might notice. You might have a sudden deterioration, like 24 to 48 hours after the injury. So that might be, some memory issues, behavior issues, and speech deficits as well. And then the epidural hematoma, remember, we said that was a medical emergency, and that is where you'd have the bleeding between the space between the dura mater and the skull. So there's likely going to be some unconsciousness there. So a decreased level of consciousness. You want to watch out for vomiting and dilation of the ipsilateral pupil. Remember, we just said that ipsilateral just meant one-sided. So, one on one side is what that would mean. So a full neurologic exam might involve some type of scans or x-rays or something like that, like CT scans or MRIs. MRI, which stands for magnetic resonance imaging, it generates a detailed picture of the body structures, and it may involve using some type of contrast dye or something like that. So compared to like just x-rays or CT scans, MRIs provide more in-depth contrast of the soft tissues. So it sharply differentiates healthy, benign, and cancerous tissues. And it, helps to, reveal like blood vessels and things like that when we're talking about using an MRI. So treatment of our head injuries. The big thing, we want to make sure we keep our intracranial pressure down. You don't want that intracranial pressure to increase. So if there's any fragmented bones that might be Remember we talked about like that depressed skull fracture where the skull will go inward. So then maybe you might have bone fragments or something that could be in the brain or lacerated the brain. You want to make sure you get those removed. And number one, always remember patent airway. Make sure our patient's airway is patent. Keeping the head of the bed elevated 20 to 30 degrees is also going to help keep that intracranial pressure from rising. You want to monitor the patient's neurologic status. I have posted a video for you on performing a complete neurologic assessment. So make sure you do view that video as well on how to, complete that neurologic assessment. Might need some diuretics to help get that fluid off the brain as well to, keep that intracranial pressure from rising. There is a care plan in your book that will help you as well. It's on page 505 of your book to help you, kind of see some of the goals and interventions for patients with increased intracranial, or not just with head injuries in general. So if the intracranial pressure begins to get too high and stays high for a long period of time, then obviously, death is going to occur because they're going to, lose function in that area of the brain. So the space in the cranial vault is a small area. Not a lot of space in there. You have the brain and everything that's in there to help protect the brain, the meninges, the skull, everything's there. So it's a small amount of space. So if you have any type injury or lesion or things that's causing swelling of the brain, or anything that's causing a leakage of fluid such as blood, or something that might be causing the cerebrospinal fluid to increase, then it can cause an increase in the intracranial pressure that's in the brain. And so when you have pressure against those cerebral veins and arteries, it interferes with the blood flow, which can cause ischemia. And ischemia, we know, is a loss of or a lack of blood not being able to get to a certain area. In this particular instance, we're talking about unable to get to the brain, a certain area of the brain. So if the blood can't get to a particular area of the brain, then that particular area of the brain is going to have a loss of oxygen, because of course the blood carries the oxygen. So if that particular area of the brain is not getting oxygen, then it's going to eventually die if the situation is not resolved. So we have to, in these head injuries, we have to make sure we keep the intracranial pressure down. And because if it does get too high and stays high for a long period of time, then death is imminent, unfortunately. And so when we're talking about the space in the brain and the interstitial fluid itself takes up about 80% of that cranial vault. Then you have cerebrospinal fluid that takes up about another 10%, and then blood that takes up about another 10% of the intracranial area. A normal intracranial pressure should be anywhere from about 10 to 15 millimeters of mercury. So this diagram is in your book on page 507, but it kind of further elaborates on what we were just talking about in the previous slide. So there's different types of things that can cause brain tissue injury. So like a head trauma, a stroke, even an infection, some type of inflammation, a tumor, an abscess, or things like that can cause the brain, that cause inflammation. And then you get cerebral edema. So if you get this cerebral edema, then there's a vasodilation with the vessels, which will increase the intracranial pressure. And as we said previously, if that pressure increases, it's going to cause ischemia, which or cause a decrease in blood flow to that particular area of the brain. So if it causes a decrease in blood flow to that particular area of the brain, it's going to cause ischemia and hypoxia, because if there's no blood getting to that area, then there's no oxygen getting to that area. So if there's no oxygen getting to that area, then that area of the brain is going to die. And eventually, if it's not resolved, death is going to occur. Okay, so there's some particular signs for increased intracranial pressure. Cushing's triad is your classic signs of increased intracranial pressure. With Cushing's triad, Cushing's triad, there's a rise in the systolic blood pressure, a widening pulse pressure. So the pulse pressure is the difference between the systolic blood pressure and the diastolic blood pressure. So say for instance, my blood pressure is 160 over 100. The difference in that would be 60. That's called my pulse pressure. So a widening pulse pressure is when those two come begin to go further apart. So say for instance, your systolic blood pressure begins to rise and your diastolic blood pressure begins to get lower. So it's widening. So say for instance, with increased intracranial pressure, your blood pressure might be 200 over 60. That's a widening pulse pressure. Bradycardia with a full bounding pulse is also part of that Cushing's triad. And then these individuals are going to have a rapid or irregular respirations as well. But just briefly to discuss Glasgow Coma Scale again, remember that's checking the patient's eye response, their verbal response, and then their motor response. And so that video tells you basically how to do the whole particular scale. The higher their score is, the more alert they are. The lower their score is, the closer they are to being in a coma. So there are some other signs of increased intracranial pressure as well. Some early signs and symptoms for increased intracranial pressure might be decreased level of consciousness. Like I said, these head injuries, you always want to monitor their level of consciousness, because if their level of consciousness is going down, then their condition is likely worsening. They may have some agitation, some lethargy, some confusion or disorientation. They also might have some pupillary changes, so checking their pupils. Are they equal, round, and reactive to light? Do they have headaches? Do they have decreased strength? Are they not moving as much, not able to move their extremities as much? They might have some reduced visual acuity as well. And some late signs of increased intracranial pressure, they might be in a stupor or even a coma. Maybe have some nausea and vomiting, high blood pressure, and then of course we talked about that widening pulse pressure and bradycardia. And bradycardia is decreased heart rate less than 60 is bradycardia. And if they're terminal, get to a point where they're terminal, they may be in a coma, have some respiratory irregularities, not breathing as well. Pupils may be dilated. So with these patients, you want to make sure you complete a thorough neural assessment. As I stated before, there is a video on Blackboard for you to watch on how to do a thorough neural assessment. So make sure you do check that out as well. Another thing I want to point out with this as well, with increased intracranial pressure, They might it might be have some decorticate or decerebrate posturing. So there's a video on Blackboard as well regarding decorticate and decerebrate posturing. So make sure you look at those videos as well. So back to the assessment. So we're talking about, you know, doing a thorough neural assessment. There may be, you might notice some clear drainage, clear nasal drainage, or clear drainage coming from the ear. If you do notice that, you probably want to suspect cerebrospinal fluid. So if you suspect cerebrospinal fluid, one way you can test is to check the fluid for glucose. So if it is positive for glucose, then we, you know, have a good indication that it's cerebrospinal fluid that's leaking. Glasgow Coma Scale, you want to make sure you're using your Glasgow Coma Scale and checking as well. And there's a video on Blackboard as well on how to use the Glasgow Coma Scale. But just briefly, we know that the Glasgow Coma Scale measures eye response, verbal response, and motor response. And the higher our score, the more alert our patient is. The lower our patient's score, the more likely they are in a coma. Okay, so we have a couple complications of increased intracranial pressure. Hydrocephalus being one, which is basically an excessive accumulation of the cerebrospinal fluid in the cranial area. Diabetes insipidus. Please don't confuse this with diabetes mellitus. They are not the same thing, so don't think that they are. Diabetes insipidus is basically a result of inadequate amount of antidiuretic hormone. So the antidiuretic hormone is released through the pituitary gland. So if there's some type of damage or edema or something with the pituitary gland that's causing it to not be able to release that antidiuretic hormone, which we know the antidiuretic hormone is what helps to control or prevent us from just urinating constantly, you know, constantly urinating. So if it's not releasing that antidiuretic hormone, then what do you think is going to happen? You're going to continuously have excessive or copious amounts of urine, also called polyuria. So remember these terms, polyuria. You know, you need to get used to these medical terms if you're not already. But you're going to see copious, large amounts of urine with diabetes insipidus. Polydipsia, which is excessive thirst. You're going to notice that. You're going to probably notice signs of dehydration. So what you're going to do, obviously, we're going to monitor. Well, first of all, we need to figure out what's causing the issue so we can, you know, try to alleviate the problem. But we want to, as the nurse, we want to make sure we're monitoring INOs, right? So monitoring our INOs on a regular basis, because if this person's having copious amounts of urine, we want to make sure, you know, try to, you know, get that decrease. We want to monitor them for hypovolemic shock, which we'll talk about in a later chapter. We want to monitor their weight daily. Make sure they're not losing weight due to losing all this fluid through the urine. We want to monitor them for dizziness, muscle weakness. So if they're having dizziness and muscle weakness, obviously they're going to be at increased risk for falls, right? So we want to monitor them, you know, for that, for fall risk as well. So this slide is kind of just reiterating some of the things we've already talked about for our patient with increased intracranial pressure. We're going to do a complete neural assessment, and you're going to watch that video on how to do that. monitor their level of consciousness, monitor their pupil reaction. So remember, PERLA, our pupils equal round and react to light. We're going to monitor their neuromuscular activity, their vital signs, and they're likely going to be on neural checks every 15 minutes to 2 hours as well. So when we have a patient that has had some type of injury and we're monitoring them for an increase in intracranial pressure, we immediately want to report, some of those things that we had talked about. They're having a change in their mental status, so they're becoming more restless or more excitable than they were. Or opposite, maybe they're having a deepening stupor, they're decreasing in their level of consciousness. The headache is, intensifying. They're vomiting, projectile vomiting, not just, normal vomiting. They're projectile vomiting. So all these things we want to make sure we report to the physician immediately, because these are all signs that the pressure is continuing to increase. And as we stated previously, if we don't get that pressure down, death is going to occur. Other things which we've already covered, which we want to make sure we report immediately, if there's unequal pupil size or abnormal pupil reactions. If you notice that leak in cerebral spinal fluid from the nose or the ear, so you test it with test for glucose to see if there's any glucose. If there's glucose in that clear fluid, then you know that's likely cerebral spinal fluid. Want to report any changes in their blood pressure. Do they have that widening blood pressure? Are their respirations getting irregular? Their pulse, how's their pulse? Is it slow? Is it bounding? So we want to make sure we report all those things immediately, because their condition is worsening. Okay, so what are our goals, for this particular patient? We want to maintain our cerebral perfusion or pressure in the brain. We want to reduce the intracranial pressure. We want to obviously maintain adequate respirations, for this patient. If they're not breathing, nothing else matters, right? So we make sure they're breathing okay. Protect them from injury. Remember, we said some things can cause them to be dizzy or weak, or things that's putting them at risk for falls or other things like that. So we want to make sure we do things to protect them from any type of injuries. Help them to maintain normal functionings, because they, may get weaker and lose functioning in some areas of the body. And prevent any complications. We talked about a couple of complications. So we want to, make sure we do things that will prevent any of those complications. So what are our goals for, our patient with increased intracranial pressure? Obviously, we want to maintain cerebral perfusion, so the pressure in the brain. Make sure we're maintaining that appropriately. We want to reduce that intracranial pressure if it is increasing. Maintaining adequate respirations. Obviously, if they're not breathing, nothing else matters. So make sure they're breathing okay. Protect them from injury. Remember, we said some of these in some situations they can be dizzy, they can be weak, things that are putting them at risk for falls. So we want to, make sure they're not having any injuries. Maintain normal body function, so they are getting weaker, helping to, do things to maintain their body function and preventing, any complications from occurring. You want to do things that's not going to cause the intracranial pressure to increase. So we don't want things like constipation. We don't want our patient constipated, because if they're straining or doing things like that, that's going to increase the intracranial pressure. So anything that they would, be pushing down, using that Valsalva maneuver where they're pushing down, We don't want them to do that because that's going to increase the intracranial pressure. We don't want them to hyperextend their neck or, rotate in their head. We don't want them to do things like that. We don't want our patient to flex at the hips because all those things can, increase the intracranial pressure. And so remember, we said elevating the head of the bed 20 to 30 degrees is going to help with that, keep that intracranial pressure down. Doing your neural checks, as we talked about, reporting, any changes right away. Maintaining a proper airway. And then how, talked about normal body function and doing things like range of motion exercises to help, because you can get pretty weak in a short amount of time if you're not using certain extremities. So want to make sure we keep on helping them to use those extremities as much as possible. So remember, we said any type of head injury, we want to monitor or assume that there's a spinal cord injury until we've been proven otherwise. Definitely, if we know there is a spinal cord injury, we want to, protect, do things that are going to protect the spine. We have 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, a sacral, and a coccyx bone. That an injury to either of these areas could cause different types of symptoms in our patients. So this diagram is actually in your book on page 510. You'll see there. And as I stated before, different types of injuries to different areas can cause different types of injuries to our patient. So say for instance, if we were to receive a fracture in the lumbar area, we might have a paraplegia. Our patient might be paraplegic, which does not include all 4 limbs. Whereas when we get higher up in the cervical area, say like C6 or something like that, if our injury is there, our patient may be a quadriplegia, meaning all 4 of the limbs are affected by that particular injury, and so they may be paralyzed in all 4 areas and unable to move. The table on table 22.1 on page 512 actually details out very nicely how your body or how your patient may be affected based on where the injury is located in the body. For instance, the book talks about if the injury is at C1 to C3, there's no respiratory function, usually fatal, unless immediate emergency help is available to establish respirations. And there'll be a quadriplegia for sure. And so, going on down, say if the injury were T1 to T10, normal arm movement and strength, loss of bowel, bladder, and sexual function. And so, it kind of goes through each of those areas. So make sure you take a look at that so you'll know what to expect, what you might expect if your patient has an injury to a certain area of the spine. So lots of different things can cause injury to our spinal cord. A big one that, we see a lot, of course, are motor vehicle accidents. So, cars accidents can, cause spinal cord injury. falls, any type of falls, you can injure your spine. Sports injury, we see those all the time. Gunshot wounds and stabbings, unfortunately, we see a lot of spinal cord injuries in those type situations as well. So different types of spinal cord injuries. It may not always be a complete break. You might have a fracture. You might have a dislocation where, it's completely, where it's separated, or subluxation, where there's partial dislocation of that area of the spine. So here again, we talk about different areas of the spine and what you might see with your patient. So L1, which is the lumbar area, if there's a injury there, you might see the patient being paraplegia. T6, paraplegia, and we're up to C6, we might see quadriplegia at that point, and C4 definitely you'll probably see quadriplegia. But again, that table to help you through that is on page 512. So some interventions with our patient with a spinal cord injury. Obviously, we're going to make sure we complete an accurate motor and sensory assessment for this patient. Maintain a patent airway. Always, always, always maintain a patent airway. If our patient is not breathing, nothing else matters, right? Spinal immobilization. So we want to immobilize our patient's spine. If they're in the hospital, obviously they're likely going to use some type of traction. And your book defines or shows you several ways this can be accomplished using traction to help immobilize the spine. If you if you're not in the hospital, say you witness an accident or see someone out and suspect that they have spinal cord injury, you can use towels or whatever things you might have to try to immobilize that spine, because you don't want any movement of the spine, which can cause further injury to that spine. Oxygenation if needed, and ventilator if needed as well, because remember we said the higher up that injury is, then more likely we're going to see issues in the respiratory function as well. Depending on where the injury is, they might have some urinary incontinence, and so may need to manage their urinary system with a Foley catheter to prevent any or not even necessarily incontinence, I should say. It could be that they can't eliminate, and so maybe they're retaining fluid for some reason based on where the injury is as well. And so we want to prevent any bladder distension as well. So they might need a Foley. They might need IV fluids as well. So the spinal cord is the primary pathway for nerve impulses traveling between peripheral areas of the body and the brain. And it contains sensory to motor pathways as well. And so they're followed by nerve impulses to the central nervous system. The central nervous system is where the brain and the spinal cord is housed. So when we have spinal shock, there's a disruption in that nerve communication pathways from the upper and lower neurons. So there's no communication there. And so as a result, there's a loss in sensation below the site of the injury. So, say for instance, the injury is at T6, there's no sensation below that area. So you'd have a complete loss of all your reflexes, your motor and sensory activity below that level. It would affect all the systems. Um, Temporary, usually it's temporary, usually um, anywhere from right after the injury occurs to up to 48 hours or even some weeks it can last as well. So another complication of a spinal cord injury is autonomic dysreflexia. Now this occurs mainly in patients with injuries at or above T6. So if their injury is at or above the T6 level, they're at risk for developing this autonomic dysreflexia. And so it's a condition where the involuntary nervous system overreacts to the external overreacts to external stimuli. So like a distended bladder or rectum can actually cause this issue. It can be dangerous to patients because it causes vasoconstriction of the arterioles, which can cause elevation in the blood pressure, cause extremely high blood pressure, and lead to seizures, retinal hemorrhage, or even a stroke. So it can be, dangerous to patients. So other signs they might have bradycardia, which we said again is a heart rate less than 60, blurred vision, throbbing headache, um, serious diaphoresis above the injury, as well as nausea. So how do we treat autonomic dysreflexia? So this is a medical emergency, as we previously stated, because of the vasoconstriction can cause an elevation in the blood pressure, which can lead to seizures and retinal hemorrhage or even possibly a stroke, as we said. So first of all, we want to, assess and find out what the cause of the condition is and remove whatever that stimulus is. So like we said, if it's a distended bladder, then do we need to insert a catheter to relieve that bladder? So remove whatever that issue is. Of course, if they're having high blood pressure, we want to get that blood pressure down immediately. So giving antihypertensives, elevating the head to, try to help relieve some of that pressure as well, and maybe providing steroids to decrease inflammation. Just a few other complications that you might see from spinal cord injuries. They might have muscle spasms, orthostatic hypotension. So what is orthostatic hypotension? So that is where, and this is how you would check your orthostatic hypotension as well. So maybe we're in a lying position. We go from lying to sitting. Our blood pressure will drop, and then we go again from sitting to standing, and our blood pressure drops further. So that puts us at risk for that orthostatic hypotension. So when we're changing positions, our blood pressure keeps dropping. Deep vein thrombosis, infections, skin breakdown. If we're not moving, we're at risk for that skin breakdown, and renal complications as well if we're not moving about. So this picture also is in your book. This is an example of how you would log roll, because if you have a patient with a spinal cord injury, again, we don't want to, we want to protect the spine and immobilize the spine. So we're going to log roll the person as one whole unit to prevent from moving that spine around and causing further injury. All right, just a couple more slides here. Guidelines for patients with low back pain and spinal cord injuries, and even as nurses, things that they teach us to prevent further back injury. So you want to bend at your knees, right? We've learned this all, previously. Bend at your knees with a straight back. Um, you want to carry things close to your body. So when you bend at your knees, lift something up, keep it close to your body. Even when you're walking with that item or box or whatnot, you want to keep it close to your body. Performing back exercise twice a day. Maintain appropriate body weight. So if you're overweight, try to lose weight. A lumbar pillow might even be helpful when you're sitting or even driving for long periods of time. Walk around every 2 hours. If you have a job or something that causes you to sit all the time, get up and move about, not just sitting there. And consider how to safely perform a task before starting to do it. So know what you're doing before you start doing something so you don't cause injury to your back. So this is a list of don'ts to prevent, back injury. Same thing. Even, us as nurses, same thing. You don't want to prevent back pain or back issues. That's why they tell you when you're performing care for a patient, raise the bed to your height, to appropriate level, so you're not leaning over, causing issues with your back. So do not lean over. Yeah, just what I just said, lean over when bending your knees. Do not reach to lift items or heavy items. Do not stand or sit for long periods of time. Remember we said get up, move around every so often. Do not sleep with your legs out straight without a pillow cushion in them. Do not bend from the waist to pick up an item. Remember we said stoop down to pick it up. Do not twist side to side to lift things as well. All things we can do not just for our patients to help prevent back injury, but definitely if our patient has back issues, we don't want to prevent any further back issues